Welcome back to Health Code Blueprint. Diabetes ICD-10-CM coding can be tricky, even for experienced coders. Before we dive in, a quick note. This video is for educational purposes only and does not constitute legal, billing, or compliance advice. Always follow official ICD-10-CM guidelines and your organization's policies. In this video, we'll walk through real-world cases, assign the correct diagnosis codes, and explain the coding rationale step by step using ICD-10-CM guidelines and AHA coding clinic guidance. Let's get started. Alright, let's review the 3 pillars of accurate diabetes coding, the foundation for every case we'll cover today. First, recognizing causal links. When ICD-10-CM assumes a connection between conditions and when the provider's documentation must clearly establish it. Second, defining the diagnosis. Understanding diabetes status, pre-symptomatic, hyperglycemia, history of, or remission. Each leads to a different coding pathway. Third, the documentation bridge. Translating clinical language into precise ICD-10-CM codes. Accurate documentation is key to compliant coding. These pillars guide everything we do in coding, so let's walk through each one using real-world examples. Here's the key principle. In ICD-10-CM, the word with can only be interpreted as a cause and effect relationship when the alphabetic index explicitly links the two conditions. AHA Coding Clinic reminds us that with does not automatically mean one condition caused the other. Sometimes it simply means the conditions coexist. So, when the index doesn't establish that link, the provider must clearly document the causal relationship for a combination code to be assigned. Let's look at 2 scenarios, one where ICD-10-CM assumes the link, and one where it doesn't. Let's start with a scenario where ICD-10-CM does assume a causal relationship. Scenario. The assessment states, diabetes with peripheral circulatory disorder, diet controlled. Correct coding. E11.51, type 2 diabetes mellitus with diabetic peripheral angiopathy without gangrene. Rationale. ICD-10-CM assumes a causal link between diabetes and peripheral vascular disease. Because the index links these conditions, the provider's documentation is enough to assign a combination code. You might be thinking, but peripheral circulatory disorder isn't exactly what the index says. According to the AHA Coding Clinic, ICD-10-CM assumes a relationship between diabetes and peripheral arterial or vascular disease, including peripheral circulatory disorder. All of these fall under the umbrella complication of peripheral angiopathy, so the combination code is correct. Additionally, remember, if the type of diabetes is not documented, the default code is type 2 diabetes mellitus E11. Now that we've looked at a scenario where ICD-10-CM assumes a causal relationship, let's shift to situations where the classification does not assume a link. In these cases, the coder must rely entirely on provider documentation to determine whether the conditions are related. Let's walk through 2 examples. First, we have diabetes 1.5 with hypertension. Even though the provider documents the conditions together, ICD-10-CM does not assume a causal relationship between diabetes and hypertension. The word, with, isn't enough here. Because the alphabetic index does not link these two conditions, and the provider hasn't documented a cause and effect relationship, we must code them separately. Since no causal link is documented, the conditions are coded separately. If a more specific term is documented, such as diabetic hypertension, or hypertension due to diabetes, then a combination code could be used to capture the relationship. Without that documentation, each condition must be coded on its own. That leads us to I-10 for essential hypertension and E13.9 for other specified diabetes without complications. Now let's look at the next scenario, type 1 diabetes with a pressure ulcer. Again, ICD-10-CM does not assume a causal link between diabetes and pressure ulcers. Pressure ulcers are typically caused by prolonged pressure over bony prominences, not by diabetes itself, unless the provider specifically documents the ulcer as a diabetic complication. In this case, the provider simply lists the 2 conditions without linking them. So, we assign E10.9 for type 1 diabetes without complications and L89.112 for the stage 2 pressure ulcer of the right upper back. Both of these examples reinforce the same principle. When ICD-10-CM does not assume a relationship, the provider must clearly document the causal link. If the documentation doesn't support it, the conditions must be coded independently. Now let's move into the second pillar of diabetes coding, defining the diagnosis. Here, we shift focus from causality to the patient's actual clinical status, because how diabetes is documented directly determines the code we assign. Diabetes isn't coded the same way in every encounter. It exists along a clinical spectrum, and our job is to identify exactly where the patient falls based on the provider's documentation. On one end, we have presymptomatic diabetes, where early markers are present but no symptoms have developed. Next is hyperglycemia, often noted as poorly controlled, which requires a specific coding pathway. Then we have history of diabetes, which may or may not apply depending on whether any active complications remain. Finally, remission is a very specific clinical status that must be clearly documented by the provider. Each of these terms has different coding implications, so understanding the distinctions is essential for accurate ICD-10-CM assignment. In the next slides, we'll explore real-world examples that show how to translate these documentation phrases into the correct diagnosis codes. Let's see how this plays out in practice. Next, let's look at how documentation of poorly controlled diabetes impacts code selection, because this phrase shows up all the time in real-world charts. In our first scenario, the patient is seen for poorly controlled diabetes, and both metformin and Lantus are increased. The provider doesn't document the diabetes type, so ICD-10-CM automatically defaults to type 2 diabetes. And whenever we see poorly controlled, that maps directly to hyperglycemia. So the correct codes here are E11.65 for type 2 diabetes with hyperglycemia, along with Z79.4 for long-term insulin use and Z79.84 for long-term oral hypoglycemic use. Now let's compare that to the second scenario, where the patient has diabetes 1.5, or LADA, managed as type 1. The A1C is elevated at 8.8, and the patient is on insulin. Even though LADA behaves clinically like type 1, ICD-10-CM classifies it under the E13 category, other specified diabetes. And just like before, poor control still means hyperglycemia, so the correct code becomes E13.65, along with Z79.4 for long-term insulin use. Both of these cases highlight the same principle. When the provider documents poorly controlled, we code hyperglycemia, and the diabetes type is determined either by documentation or, if not stated, by ICD-10-CM default rules. Now let's look at a key distinction in diabetes coding, knowing when history of truly means the diabetes is resolved, and when it doesn't. The phrase alone isn't enough. What really matters is whether the patient still has an active diabetic complication. If there are no active complications and the provider clearly documents a past condition, then a history code is appropriate. But if the patient still has an active diabetic condition, even if the note says, history of, the diabetes must be coded as active. This distinction completely changes the coding pathway, so it's important to evaluate the documentation carefully before assigning the code. In this scenario, the provider documents a history of diabetes after gastric bypass, the patient's A1C is 5.6, and there are no active diabetic complications noted anywhere in the record. Everything supports that the diabetes is truly resolved. Because of that, the correct code is Z86.39, which captures a personal history of other endocrine, nutritional, and metabolic disease. There's no conflicting documentation and no evidence of ongoing disease, so assigning a history code is completely appropriate here. In this scenario, the provider documents a history of diabetes, but the patient still has active diabetic peripheral vascular disease. And this is where the distinction we just talked about becomes critical. Even though the note uses the phrase history of, the presence of an active diabetic complication means the diabetes is still active from a coding perspective. Active disease always overrides the wording, history of. So, the correct code here is E11.51, which captures type 2 diabetes with diabetic peripheral angiopathy without gangrene. This case is a perfect example of why we can't rely on phrasing alone. We have to look at the full clinical picture. If the complication is active, the diabetes must be coded as active as well. Now let's look at two scenarios that sit at opposite ends of the diabetes spectrum: pre-symptomatic disease and documented remission. Both require very specific wording from the provider, and both lead to very specific ICD-10-CM codes. Let's start with the pre-symptomatic case. Here, the patient has positive pancreatic autoantibodies and abnormal glucose tolerance, but no symptoms yet. This is early-stage type 1 diabetes, and ICD-10-CM gives us a dedicated code for exactly this situation. The correct code is E10-A0, which captures type 1 diabetes mellitus, pre-symptomatic. We use this code when the provider documents early disease markers before symptoms appear. Now on the other end of the spectrum, we have a patient with a history of type 2 diabetes who now has sustained glycemic control, and the provider clearly documents that the diabetes is in remission. That specific wording is important, because ICD-10-CM only allows the remission code when the provider uses the term remission. So, the correct code here is E11A, which captures type 2 diabetes mellitus without complications, in remission. It's also important to note that terms like history of or resolved are not interchangeable with remission. If the provider doesn't explicitly document remission, a query would be needed. These two cases highlight how precise documentation, whether it's early disease or remission, directly drives accurate code assignment. This slide brings everything together. Our job as coders is to take what's written in the clinical note and translate it into the correct ICD-10-CM code. And as we've seen, small details in the documentation, like with, poorly controlled, history of, or in remission, can completely change the coding pathway. When the documentation is clear, coding is straightforward. When it's not, that's when a query becomes necessary. So, this step from clinic to code is all about accuracy, clarity, and making sure the coded data truly reflects the patient's clinical picture. Here's a quick documentation checklist to make sure we're capturing diabetes accurately and consistently. First, we always start with the purpose of the encounter, why the patient is being seen today. Next, confirm the diabetes type, whether it's type 1, type 2, LADA, or unspecified. Then look for the current status, active disease, pre-symptomatic, or remission. After that, identify any complications and make sure the provider clearly links them to diabetes when ICD-10-CM doesn't assume the relationship. And finally, check for treatment details, like long-term insulin or oral hypoglycemics, since these impact Z-code assignment. This quick checklist helps ensure the coded data truly reflects the patient's clinical picture and supports clean, compliant claims. Before we close out, let's quickly revisit the key principles that guide accurate diabetes coding. First, know when ICD-10-CM assumes a causal link and when the provider must clearly document it. Second, always define the diagnosis based on the patient's current clinical status, active disease, pre-symptomatic, history, or remission. And third, use documentation as the bridge that connects the clinical picture to the correct code. These principles anchor every scenario we've reviewed today. And finally, precision in documentation is what makes accurate coding possible. Small wording differences, like poorly controlled, with, history of, or in remission, completely change the coding pathway. When providers document clearly and specifically, coders can assign the correct combination codes, capture complications, and reflect the true clinical story. Precision isn't just helpful, it's essential for compliant, accurate diabetes coding. Thanks for watching Health Code Blueprint. See you in the next video.